evening, everyone. We've heard from Dr. Kaparde about the WHO's NTB strategy, and that has made the role of laboratory very crucial because we are the providers of early diagnosis. However, in population that is HIV infected and we need to diagnose TB, in them it's a real challenge for the laboratory person because of the porcine bacillary nature of the sputum, more of extrapulmonary lesions, and also that multi-drug resistant tuberculosis is twice as common in this population. And therefore, the main need is for early diagnosis and treatment. In an HIV-infected population for TB diagnosis, the modalities that are commonly used are sputum smear microscopy, culture, expert MTB-RIF assay, and urine LAM assay. What I like to emphasize here that it is not only important to detect tuberculosis, but simultaneously also detect drug resistance. The currently available molecular assays tell us information about anti-TB drugs that should not be used, but that is not enough, and therefore we still need to rely on culture DST, that is the conventional liquid culture DST, to find out which drugs can be used. The conventional methods of diagnosis by using acid-fast staining sputum smear microscopy is a very rapid test and very reliable test. However, it has a very low sensitivity. It requires at least 10,000 organisms per mil of sputum to detect it positive, whereas the culture is highly sensitive, but it takes a long time for the reports to come because the organisms are very slow growing. But also it has an advantage that it provides the isolate for drug susceptibility testing. So in 2011, WHO gave a policy guidance on replacing conventional sputum microscopy, and in a large setup where there is fluorescence microscopy being done to be replaced by what is called as light emitting diode microscopy. This which works on the principle of fluorescence microscopy, and it has advised that it be phased in and provide an alternative to conventional ZN microscopy. Our experience at KEM also showed us that it was very sensitive and specific. Coming to culture, there are various liquid culture methods available, but the only one that is recommended for drug susceptibility testing by WHO is the MIDGET 960. When should one do culture? Culture should be requested in all retreatment cases, be it relapse, be it failure, or be it return after default, and also in all new cases, and all retreatment pulmonary TB cases where the smear is positive at the end of the intensive phase of treatment, also in symptomatic contacts of the known MDR cases, and in all extrapulmonary TB cases. A very useful assay which has become available over the last 5 years is urine LAM assay. The LAM is a lipoarabinomannan. It's a polysaccharide which is a part of the mycobacterial cell wall, and it is released from the bacterial cells and excreted in urine. And several studies have shown that it is present only in people who are having active TB disease. So there is a point of care assay which has now commercially become available and which has shown useful diagnostic accuracy. The assay looks something like this. The principle is immunochromatography, and the results are available within 30 minutes. The assay has about varying sensitivity in several studies. It has shown to vary from 38 to 100%, and the specificity also has been shown to vary from 50 to 95%. But when the results of LAM assay are combined with sputum microscopy or with expert assay, the sensitivity has shown a remarkable increase. Similarly, in patients with lower CD4 counts, it has shown an inverse proportion. That is, in people with lower CD4 counts, the sensitivity has been shown to be very high, whereas the specificity remains same at all CD4 levels. So therefore, the test is useful in seriously ill patients who are unable to bring out sputum, and where other tests of TB are not possible to do, this test is going to be very useful. Advantage over sputum microscopy, which is used, is that urine is easy to collect and store, and also the infection control risks are not there. Coming to molecular assays, we have been using expert assays for the last 5 years. It's the preferred initial diagnostic test in all MDR TB cases, in all HIV infected patients and in children. It detects not only Mycobacterium tuberculosis, but also detects resistance to rifamycin. And the line probe assay is also WHO recommended for all smear positive cases, and it can detect resistance to both rifamycin and INH. So expert TB assay is a closed cartridge-based nucleic acid amplification assay, and the results are available within 2 hours, and it can be directly performed on the sputum sample. And the results are available in the form of either MTB detected, not detected, and if it is detected, what is the concentration, like very high, high, low, or very low, and in addition, whether the RIF sensitivity is also given, that is rifampicin resistance detected or not detected. The sensitivity and specificity of this assay when compared to culture is high in case of sputum smear positive samples as compared to smear negative. So in HIV infected patients, mostly it would be smear negative. So it is advisable to do more than one sample testing by the same assay, which improves the sensitivity. As you can see in the lower one, you can see that as the study was done, where there were 3 sputum specimens tested, and the sensitivity markedly improved. This was our experience with expert assay on extrapulmonary samples, and we found 84% sensitivity and 97% specificity with the expert assay, and we could pick up almost 25% of CSF samples, and all these were smear negatives. Similarly, for pulmonary TB, we had done a study as a part of my postgraduate students' dissertation, and what we found that the sensitivity was 77.78% and the specificity was 96.8%. The sensitivity in smear positive, culture positive cases was 100%, and the sensitivity in smear negative culture positive cases was around 62%. Under the program, under the RNTCP, from Jan 15, we started testing all HIV infected patients as the first initial test, and so far we have done 278 tests, of which 21% were detected as Mycobacterium tuberculosis, and almost 1/4 of them was RIF resistant. And all of these were smear negative. Line probe assay is the recommended molecular test by WHO for smear positive cases only, but there are studies available in literature where this assay has shown equivocal results even with the sputum negative samples. The assay strip looks something like this. You can see mutations in various genes, and when you see the RPOB gene mutation, it indicates RIF resistance. When you see mutation in the CATG or the INHA region, it indicates INH resistance. So when you have a mutation in the INHA region, it indicates low-level resistance, meaning thereby you can continue INH in the regimen, but you have to use a higher dose. Whereas if you see a mutation in the CATG region, That means it's a high level resistance, and therefore you cannot use INH in the treating regimen, and it should be replaced by prothionamide. In May 2006, WHO issued a policy guidance wherein it recommended the use of second-line LPA as the initial diagnostic test, replacing the conventional liquid phenotypic DST test to detect resistance to fluoroquinolones and second-line injectable drugs. And this test can be performed directly on the sputum sample, or it could be on a mycobacterial isolate. And the only hitch here is what mutations you see in this assay are not very well correlated phenotypically for two drugs, that is moxifloxacin and gatifloxacin. And therefore, for these drugs, you need to confirm susceptibility by the conventional culture DST. So conventional culture DST can still be used in the evaluation of patients with a negative second-line LPA. For the drug resistance, there are some important considerations which I would like to bring to your notice. The first one being that whatever molecular methods we use for drug resistance detection, they are the ones which detect genes which are encoding for resistance in specific resistance determining regions, and which are the indirect measures of phenotypic resistance. And as of now, we do not have knowledge of all the mechanisms which bring about drug resistance, and we know of certain silent mutations. That is, we see the mutations in the genetic region, but actually phenotypically the drug is useful. And therefore, we must remember that molecular diagnostics, as they are available in the current form, they can only provide information about anti-TB drugs that should not be used. And except for rifampicin, a susceptible result by a molecular platform has to be confirmed by conventional liquid culture DST. So how do you overcome this situation? In future, there are studies showing which are trying to find out whole genomes of the organism by whole genome sequences. There has been a lot of progress in this. They started with doing pyrosequences, then they went on to do next generation, and now is the time for whole genome sequences. So let us hope that this is what will give us a comprehensive picture to predict the phenotypic susceptibility. So to summarize, in HIV infected, expert is the first test that should be used for TB diagnosis. And if we detect RIF resistance, we should start WHO recommended regimen for drug-resistant TB, simultaneously do a baseline liquid culture DST for pyrazinamide, ethambutol, second-line drugs. And then when the DST results become available, if necessary, modify your treatment regimen. And in seriously ill patients, you can make use of the urine lam assay. And since current diagnostic methods such as DST take longer time and targeted molecular tests examine only a limited number of target regions, faster, more comprehensive diagnostics like the whole genome sequences are the need of the hour. Thank you very much.